Let's just dive right into this 10-minute explainer. Today, we're going to break down the incredibly complex management of chronic obstructive pulmonary disease. And we're going to do it by following a real-life clinical case. Actually, I want you to think of me as your attending physician today as we walk through this together. COPD is progressive. It's a massive global killer. And honestly, managing it properly takes a deep, deep understanding of what's actually going on inside the lungs. So we aren't just going to sit here and read textbook definitions. We're going to address this case study with real-world examples, tracking a patient from the second he hits the ER doors all the way to his long-term outpatient plan. All right, so let's meet our patient. We'll call him Mr. H. He's a 64-year-old retired warehouse worker, and he's coming in with a massive 40-pack-year smoking history. Now, he's had this chronic morning cough for years, right? But today is completely different. He presents complaining, "Doctor, I just can't catch my breath." Over the past 3 days, his baseline dyspnea has gotten so bad that he's breathless just trying to walk a single block. And crucially, his sputum has changed from clear to this nasty yellow-green. Oh, and this was all preceded by a simple runny nose and sore throat. This classic history tells us a viral upper respiratory infection has likely tipped his chronic disease into an acute, truly life-threatening crisis. Looking at his presentation, the hypoxemia at 88% on room air, along with his heavy accessory muscle use, well, they paint a very clear picture of a patient in crisis triggered by that recent viral infection. His respiratory rate is cranked up to 26, heart rate is racing at 104, and on exam, you see a thin guy sitting totally upright, pursing his lips, just trying to squeeze out a breath. You're hearing diffuse wheezes, scattered rhonchi, and you'll definitely notice a pronounced barrel chest. I mean, these vitals and exam findings are practically screaming that this is an acute exacerbation of COPD. To solve Mr. H's medical mystery, here's our roadmap. 1. Meet the patient. 2. The pathophysiology. 3. Confirming the diagnosis. 4. Chronic management. 5. Surviving acute exacerbations. And finally, 6. The final patient plan. Okay, moving right into part 2, the pathophysiology. So the step-by-step mechanism of COPD really starts with an inhaled injury, which in Mr. H's case is decades of cigarette smoke. This smoke basically acts as a constant irritant, dragging inflammatory cells like neutrophils and macrophages straight into the airways. Once they're there, these cells dump proteases, specifically neutrophil elastase, along with a bunch of oxidants. Now, normally, your body has a defense system against this, right? Antiproteases, like alpha-1 antitrypsin. But here's the kicker. The smoke actually neutralizes those defenses, creating this massive, unchecked imbalance. The result? Unopposed elastase acts like a demolition crew, literally digesting the elastic scaffold of the alveoli, which leads to permanent structural damage and the irreversible loss of alveolar attachments. Now, notice the stark contrast between the two overlapping phases of COPD. First, we've got emphysema, the classic pink puffer. This is driven by that alveolar destruction we just talked about. It creates increased dead space, meaning the lungs are getting air, but the blood flow just isn't matching up. This wasted ventilation leads to severe dyspnea and hypercarbia, but usually the hypoxemia is pretty mild. On the flip side, we have chronic bronchitis, or the blue bloater. Here, thick mucus and small airway fibrosis cause the blood to bypass gas exchange entirely, creating a massive shunt. This leads to severe hypoxia, which in turn triggers hypoxic pulmonary vasoconstriction. Over time, that rising pressure puts a massive strain on the right ventricle, eventually leading to right heart failure, or cor pulmonale. And that is exactly why the blue bloater presents with cyanosis and edema. This mechanical failure is exactly why Mr. H has that barrel chest, and why he has to use his neck and chest muscles just to take a single breath. See, because of the loss of elastic recoil and the narrowed airways, air can get in, sure, but it can't easily get out. This expiratory flow limitation leads to what we call dynamic hyperinflation. The lungs just trap air, increasing the total lung capacity and totally flattening out the diaphragm. And when the diaphragm is flat and shortened, it generates way less force. Literally every single breath costs Mr. H immense mechanical work. Let's move on to number 3, confirming the diagnosis. So the most crucial point here is that unlike asthma, this airway obstruction is fixed. It's not going to magically reverse after a puff of an inhaler. To formally diagnose COPD, spirometry is absolutely mandatory for symptomatic patients. We're looking for a post-bronchodilator FEV1/FVC ratio of less than 0.70. And if you look at the flow volume loop, you'll see this really characteristic expiratory coving. It almost looks scooped out. Just keep in mind, we only screen symptomatic patients with spirometry. We aren't out here testing asymptomatic people. You know what else is absolutely vital? Screening for the genetic alpha-1 antitrypsin deficiency. While smoking is totally the main driver of upper lobe central lobular emphysema, A1AT deficiency causes early onset lower lobe panaciner emphysema. You absolutely must suspect this if your patient is under 45, maybe they're a non-smoker, or they have a family history of early emphysema or early liver disease. Actually, the GOLD guidelines recommend checking a serum A1AT level once in literally all COPD patients. Just remember, it's an acute phase reactant, so a normal level during an acute crisis, like the one Mr. H is in right now, might give you a falsely reassuring result.
All right, Section 4, Chronic Management.
When we break down the GOLD group guidelines, we see a massive shift in how we handle this. For years, everybody reflexively reached for inhaled steroids, but the data today is super clear. Dual bronchodilation, meaning a LAMA and a LABA combined, is the true first-line backbone of therapy. It's flat-out superior to a LABA plus an inhaled corticosteroid when it comes to increasing FEV1 and reducing everyday symptoms. So, when do we actually use steroids? Well, ICS is strictly an add-on therapy now. It gives the best results only if the patient has a history of high-risk recurring exacerbations and blood eosinophils greater than 300. But listen, there's a major trade-off here. While triple therapy does decrease exacerbations, it significantly bumps up the patient's risk of getting pneumonia. Amazingly, smoking cessation provides a roughly 50% reduction in the rate of lung function decline, 50%, making it the single most powerful intervention available. Before we even start geeking out over advanced inhalers, we absolutely have to address this. It is unequivocally the most effective intervention for reducing long-term mortality. And remember, while bronchodilators are great for improving symptoms and reducing those flare-ups, only smoking cessation and long-term oxygen therapy actually move the needle on mortality. Oxygen therapy literally prevents that deadly progression to pulmonary hypertension and cor pulmonale. We prescribe this when the patient's PaO2 drops to 55 millimeters of mercury or less, or if their resting oxygen saturation is 89% or lower. But keep in mind, giving oxygen for moderate hypoxemia, say hovering around 89 to 93%, shows zero mortality benefit. Okay, jumping into number 5, surviving acute exacerbations. When a patient is struggling to breathe, our very first instinct in the ER is to just flood them with oxygen, right? But we really need to step back and ask ourselves why that exact reflex might be a fatal mistake in this scenario. Here's the deal. Over-oxygenating drives severe carbon dioxide retention through 3 major mechanisms. First, it worsens V/Q mismatch by reversing the lung's natural hypoxic vasoconstriction. Second, it blunts the patient's underlying hypoxic respiratory drive. But third, and this is the big one, it triggers the Haldane effect. This is where oxygen literally displaces carbon dioxide from the hemoglobin straight back into the blood. The result? Super dangerous CO2 retention and respiratory acidosis. And that is exactly why we must strictly titrate and target an oxygen saturation of 88 to 92%. You do not want to flood them. But a quick caveat. Hypoxemia kills a lot faster than hypercapnia, so hit that 88 to 92% target carefully but confidently. If the patient's CO2 rises and their pH starts tanking, starting non-invasive ventilation early is astonishingly effective. We're talking about a 59% reduction in mortality. 59%! It also slashes the need for intubation by 58% and dramatically cuts down how long they stay in the hospital. We pull the trigger on NIV when the patient has moderate to severe dyspnea, an elevated PaCO2 with an acidotic pH, or a respiratory rate pushing over 25. For the medical management of the exacerbation itself, we have to follow these exact steps. First step, aggressive inhaled bronchodilators, usually ipratropium and albuterol, to rapidly reverse any acute bronchoconstriction. Second, we hit them with a short burst of systemic steroids, like prednisone, 40 milligrams for 5 days. This reduces the rate of treatment failure and shortens their hospital stay, though to be clear, it doesn't reduce mortality. Third, targeted antibiotics for 5 days. We give these because Mr. H has increased sputum purulence, which is a massive red flag for a bacterial trigger, like H. influenzae or S. pneumoniae. Oh, and please skip the mucolytics. They have absolutely zero proven benefit during an acute exacerbation. Finally, number 6, the final patient plan. Let's summarize our strategy here as his attending care team. In the acute phase, we reverse his immediate crisis with those bronchodilators, a 5-day steroid course, targeted antibiotics, and strictly controlled oxygen. Then, once he's stabilized, we transition to chronic maintenance. Since he was totally untreated before, but is now clearly high risk due to this hospitalization, we're going to start him on a LAMA/LABA dual inhaler right away. We'll also check his blood eosinophils to see if he eventually warrants an inhaled corticosteroid. And finally, for his long-term trajectory, we aggressively pursue smoking cessation, make sure he's fully up to date on his flu, pneumococcal, and RSV vaccines, get him enrolled in pulmonary rehab, and run that one-time alpha-1 antitrypsin lab test. I want to leave you with this final thought. Given what we now know about the true mortality drivers in COPD, how will this change the way you structure care for the next Mr. H that walks through your doors? Look, it is so easy to get lost in the incredibly complex pharmacology of triple inhaler therapies. But if we aren't tackling the vital foundations, getting them to finally quit smoking and managing their long-term oxygen appropriately, we are completely missing the only two interventions proven to actually extend their lives. Make sure you keep that in mind on your next shift.